科学及影像学教授啊，他在Science、Nature、新英格兰Lesson 等重要的这个杂志上都发表很重要的论文。我们知道非常熟悉的打网球的实验就是由欧文首先发现的。那么在这个领域里边呢，他多的使用的是功能影像的方法来侦测这种病人的意识，做过很多突出的贡献。那么他在后期呢也开始逐渐使用脑电结合功能磁共振的方法来帮助做出这些隐匿意识的这种判断啊。那么他在这个领域里边做了很多工作，我相信在这个领域的人都是非常熟悉他的。他今天发言的题目也很有意思，今天的发言题目是 Functional Neuroimaging in the Acute Brain Injury States Implication for Prognosis and Diagnosis。我们知道欧文主要是研究慢性意识障碍的，而今天的题目他强调了是在急性期的预测急性期的这种判断。那么我们相信一定会给我们带来新的知识和新的思考以及启发。那么下面有请欧文教授。
Hello, everybody. Thank you very much for inviting me to give this 30-minute lecture. My name's Adrian Owen. I'm Professor of Cognitive Neuroscience at the University of Western Ontario. That's in London, Ontario, in Canada. Today I'm going to talk about functional neuroimaging in the acute brain injured state. And in particular, I'm going to focus on the implications that I think this work has for prognosis as well as diagnosis. Now, some of you will be familiar with the fact that over the last 25 years or so, my team has been developing fMRI, functional magnetic resonance imaging tools for assessing residual cognitive function in the scanner in patients who sustained severe brain injury. Now, most of that work has been in chronic patients, and over the years we've come up with a series of standardized paradigms that turn out to be very good for prognostication in this chronic patient population. Essentially, there are a number of conditions, beginning with the simplest idea that we look for whether the brain is still responding to sounds. We play simple sounds, we compare them to silence to look for sound-specific responses. Then by comparing speech with non-speech sound, and often that's something like signal-correlated noise, we can extract those signals that might be specifically related to the detection of speech in the brain. And finally, we've developed a number of methods for assessing comprehension, the possibility that the damaged brain may still be comprehending or understanding the meaning of those words. The simplest version of this that I can describe today is comparing what happens in the brain when the patient is played real words or real sentences with what happens when they listen to pseudo words or non-real words or sentences. And that way we're able to pull out those areas of the brain that might be responding to understanding or comprehension in the brain. Now, over the years, we've used this now in many hundreds of different patients who are either diagnosed as being in a vegetative state or a minimally conscious state. And the interesting thing is that these types of responses are actually extremely common in this patient population. In fact, about 50% of patients who are either vegetative state or minimally conscious state will produce normal or near normal responses in the speech in the speech paradigm. That is the version of the task where we compare speech with something like signal correlated noise. So about half the number of patients that we've seen over the years appear to be able to process speech normally. Now, of course, that doesn't mean that they can necessarily understand the contents of that speech, but their brain is nevertheless still processing speech as speech. Now, we used to be very excited about this in terms of diagnosis, because we, at first, or in the early days, used to think, well, perhaps this is indicative of some higher level of functioning in the brains of these patients. But there's one important experiment that I think undermined some of those thoughts, and it was carried out by colleagues of mine in Cambridge, Matt Davis, myself, and our colleagues, where we gradually sedated a group of healthy participants with the anesthetic agent propofol while they listened to these different types of speech stimuli. And the really remarkable thing, or the really remarkable result of that experiment, was that there was very little change in the brain. So even when the patients when the healthy participants went from being awake to being mildly sedated to being deeply sedated, their brains were still processing speech as speech. Now, the problem for our patients in minimally conscious or vegetative state then is that we can, of course, say nothing based on these types of responses about the patient's conscious state. Because if healthy participants who are deeply sedated and therefore demonstrably unconscious produce these patterns of activity, then when we see that pattern in a patient who is, say, vegetative, it doesn't tell us whether they are conscious or not. So in many ways, these simple activation paradigms involving speech and even speech comprehension have proven to be extremely challenging with respect to what they can tell us about the residual awareness or consciousness in this patient population. However, they do give us some important information about prognosis, and this was a paper we published in 2009, where on the vertical axis you see the coma recovery scale in a group of vegetative and minimally conscious patients 6 months after the fMRI scan. On the horizontal axis, we've just arranged the patients from those who produce no responses, those who produce responses to sounds, those who produce responses to speech and sounds, and those who appeared to be able to comprehend or understand those sounds. And what you can see is there is a very good correlation between how elaborate the fMRI responses are in this patient group and where they will be 6 months from now, what their coma recovery score will be 6 months from now. Two other important things about this graph. One is it really made no difference whether behaviorally the patients were diagnosed as being minimally conscious or vegetative. And also, it didn't make any difference what their status is right now. So this is really a comment about prognosis. It's that this activity in these speech paradigms can predict who is most likely to experience some recovery, but it can't really predict or determine what your behavioral diagnosis might be right now. Now, the question I'm going to address in this talk today is whether we can apply some of these same techniques to the acutely imaged brain. We've been seeing patients in the ICU here in London, Ontario. We've just completed a study of 17 patients. It was a mixed group of traumatic and non-traumatically brain injured patients. And what we did is we put them through exactly the same speech and speech language paradigms that I've shown you that we've used in the chronic patients. And what was interesting is the results actually are somewhat similar. That is, of the 17 patients, 11 showed good indications. So, again, something like half showed very good signs of sound perception. 9 of those 17 patients, again, slightly more than half, showed signs of speech perception. That is, activity around Heschel's gyrus and the planum temporale, specifically in response to speech when it's compared to non-speech sounds. We even found some patients who appeared to be able to comprehend speech, just as we had in the chronic patients. And that is 5 of these patients. You can see here on the right-hand side, 5 of these acutely brain injured patients. And typically, they were all scanned within the first 2 weeks after their brain injury. 5 of them produced some evidence of language comprehension. Now, as is true, or as I've told you about with the chronic patients, this doesn't tell us very much about diagnosis. I mean, it does tell us that these patients have some aspects of preserved cortical functioning that we wouldn't otherwise know. But interestingly, it gave us almost exactly the same information about prognosis that it did in the chronic group. And that is that if you arrange the patients on the horizontal axis from those who made no response at all to those who appeared to show signs of language comprehension. And in this case, on the vertical axis is the Glasgow Outcome Scale, what happened to these patients in the longer term. You see again, there is a very good correlation. The more elaborate the fMRI responses are in these patients, the more likely they are to recover. Now, I think this is an exceedingly surprising graph, in particular because unlike the chronic group, here you have many patients who are allowed to die. They are withdrawn from nutrition and hydration. So actually, if they were left to follow their natural course, the picture may actually have been even better. But even accommodating or even accounting for the fact that many of these patients were withdrawn, we still see a good correlation between the level of auditory processing and the Glasgow Outcome Scale. So again, these relatively simple fMRI tasks can be useful in prognosticating in the first 2 weeks after a brain injury while the patient is still in the ICU. Now let me turn now to talk a little bit about diagnosis. I told you about prognosis in both chronic patients and in acutely brain injured patients. And the other area we've been developing over the last few years are new methods for improving diagnosis. And many of these are based on simple naturalistic or movie watching paradigms. Now, in 2014, we published a paper. One of my senior postdocs, Lorena Narchi, and myself and our colleagues, we published a paper in the Proceedings of the National Academy of Sciences, showing, among other things, that when healthy participants view a movie, in this case it was an old Alfred Hitchcock movie, what you see are very high levels of intersubject correlation. So you're not looking at activity here, you're looking at voxels in the brain that are highly correlated across individuals. And the movie lasts between 5 and 7 minutes, and it's important that this is a relatively suspenseful movie. In this case, it's a story about a young boy, you can see him here, who finds a real gun under his uncle's bed. And he doesn't know that it's a real gun, he thinks it's a toy gun, and you know that he thinks it's a toy gun, and hence, in typical Alfred Hitchcock style, the movie becomes very tense as you start to realise that it's becoming very likely that he's going to accidentally shoot somebody. Now, many of the areas that are highly correlated across healthy participants when they view a movie like this are obvious. Primary sensory cortex, visual cortex, auditory cortex. Of course, these areas are likely to be highly synchronized across individuals because people are seeing exactly the same things. They're hearing exactly the same things. But what we're very interested in is what happens in fronto and parietal cortex. And the way we get at that is we do an ICA analysis, and we pull out the independent networks that are underlying these correlations. What you can see here is, of course, this very strong auditory and visual network, as you'd expect. But as I've already intimated, we've become very interested in this fronto-parietal network. And as you can see here, each one of the lines on this graph represents a single healthy participant, and what you can see is there's a very high level of synchrony among those participants in fronto and parietal cortex. And using various methods that I don't have time to go into here, we've been able to show that activity in this region represents how an individual follows the plot of the movie. And that is that areas where synchrony is high are where things that are very interesting that are going on, where everybody realizes simultaneously, for example, that the boy is about to fire the gun, or everybody realizes that it's a toy gun. Sorry, it's a real gun. It isn't a toy gun. Or everybody realizes that the boy himself doesn't realize that it's a toy gun. So this is an interesting index of conscious awareness, because if we can show that a damaged brain, it has exactly this same pattern of activity, or a highly correlated pattern of activity in frontal and parietal cortex, we conclude that they are following the plot of the movie. And if they are following the plot of the movie, I would argue that they are also capable of following the plot of their lives. And this is the reasoning that we've used to demonstrate that we can use responses in frontal and parietal cortex during movie watching as an index of conscious awareness. And in that paper, we compared two patients. These were two patients who had both been behaviorally diagnosed as being in a vegetative state, and their histories were very similar. Nevertheless, one of the patients, patient 1 here, although they had highly correlated activity in the auditory cortex, that is, activity that follows the same course as healthy participants, there was no similar relationship between the patient's activity in frontal and parietal cortex, shown here in red. That pattern that we know tracks the plot of the movie. Patient 2, on the other hand, showed activity in both frontal and parietal cortex that was highly synchronized with healthy participants. And on that basis, we were able to conclude that, unlike patient 1, patient 2 actually was conscious, and he was aware of where he was, who he was, and the situation that he was in. And this was based entirely on the relationship between his responses in frontal and parietal cortex when watching a movie and the responses that we had already recorded in healthy participants. Now, the beauty of paradigms like this over the simple activation tasks that I showed you at the beginning of my talk is that you can extract all sorts of measures about residual cognitive function, not just whether a patient can follow the plot, but, for example, whether they can hear. And that's what you're seeing in the first patient. The first patient shown here was producing responses in auditory cortex that were actually relatively normal. So sound and perhaps even speech perception were relatively intact. But it's these more elaborate responses in frontal and parietal cortex that I'm particularly interested in. So the question then becomes, can you do this in the acutely brain injured patients? Is it possible for us to simply look at a patient's brain, a patient lying in the ICU, using fMRI, can we track their responses to something like a movie and determine that they are actually conscious, or at least have some level of conscious awareness? Now, of course, in the ICU, in the acutely brain injured stage, most of these patients are comatose and they have closed eyes. So a movie won't work. They won't see the movie because their eyes are closed. But recently we've developed a new technique based solely on an auditory signal. And what we did is we took the audio from a Hollywood movie. In this case, it's a movie called Taken, starring Liam Neeson. And there's one part of the movie that, again, is particularly tense, particularly engaging. And that involves a scene in which Liam Neeson's daughter is hiding under her bed. She's about to be kidnapped by some kidnappers that have broken into her house, and she's talking on her cell phone to her dad, Liam Neeson, who's trying to help her avoid being captured. It's very engaging, really quite intense. And what you can see there at the bottom of this graph is that, again, when healthy participants listen to this auditory narrative, we get very high correlations in many areas of the brain. Not only, as you would expect from an audio stimulus, in the speech and sound areas of the superior temporal lobe, but also in frontal and in parietal cortex. Now, the important thing is you don't get that sort of elaborated correlation across the whole brain with other types of simple audio. So, for example, when participants listen to music like the theme tune from The Dark Knight or Game of Thrones, here you see highly correlated voxels in the superior temporal cortex, as you would expect, because everybody is hearing the same thing. But there's very little, in fact, there's no synchronization in fronto and parietal cortex. And that is because, although The Dark Knight and Game of Thrones are very engaging pieces of music, they don't have a plot. They don't pull you through the same narrative as you're going on. Everybody isn't thinking the same thing as they're listening to it. One person may be thinking about whether they enjoyed the Dark Knight movie or not. Somebody else might be thinking about where they saw the movie and what the events of that day were. Unlike the taken audio, which really does engage people and makes them all think the same thing at the same time. Now, again, we can use independent component analysis, ICA, to pull out the networks. Again, you see a strong auditory network, as you would expect, a much weaker visual network. Of course, there's very little visual synchrony here because people have, even the healthy controls in this study had their eyes closed. But in frontal and parietal cortex, again, we see strong synchrony across individuals. And again, just as we've done with the visual stimulus, with the whole movie, we've been able to show that this synchrony across healthy individuals is driven by following the plot. It's when particular twists and turns in the plot occur, activity across healthy individuals is highly synchronized. So here we have a potential paradigm for assessing the awareness, the possibility of residual conscious awareness in acutely brain injured patients in the ICU. Now, of the 17 participants, there's one other thing I want to mention. We've also, Lorena Nachi, again one of my former postdocs, also did a propofol study in healthy participants of this task. She had people listening to the auditory track from the movie Taken, healthy participants, while she gradually sedated them with propofol. On the left-hand side, or at least in the middle column here, you can see that she essentially replicated the results of the previous sedation study that I told you about earlier. And that is that as people go from being awake to mildly sedated to deeply sedated, there is very little change in the auditory network. The auditory network continues to be engaged regardless of the level of sedation. So we cannot use that particular component, the auditory component, to determine whether somebody is consciously aware or not. But look at what happens in fronto and parietal cortex. The frontoparietal network actually disappears even when the participants are just mildly sedated. And I think this is probably the best example that we have of somebody literally losing the plot. The analogy I try to use here is that, you know, if you're falling asleep in the evening, or if you're being gradually anesthetized, you might be aware that you're being spoken to, you might hear sounds, you might even respond to some sounds, but it does become increasingly difficult to, say, concentrate on a story or concentrate on a movie, because the intricacies of the plot are the things that you stop being able to follow even at levels of mild sedation. I should add that this, of course, is completely reversible when we let these participants recover from the effects of propofol. The frontoparietal network bounced right back, and of course that correlated with the return of conscious awareness. So what about patients? Well, this is data from, again, one of my former postdocs who's now on faculty here at Western, Loretta Norton. Loretta has tested only a few patients on this task. We're still really getting going with this, but here's a patient who's a 38-year-old woman, was in the ICU with a very severe brain injury. And what you're looking at here is the extent to which, or the areas of this patient's brain that correlated with the auditory component extracted from the ICA of healthy participants. And I mean, it's one of the beauties of this technique is that it's completely anatomically agnostic. So we're not just looking, say, at the auditory cortex, we're looking at the whole brain, and we're saying which voxels in this patient's brain follow the same trajectory as the voxels in the auditory network of a healthy participant's brain. And I think it's pretty amazing that it's very solidly around the auditory cortex, around the superior and middle temporal gyri. So this patient's auditory cortex was responding to this complex stimulus that involves both sound and speech in more or less exactly the same way as healthy participants. But what about frontal parietal cortex? And here the important thing is to look for which voxels in the brain, and they could be anywhere, which voxels in this patient's brain follow the same trajectory as those voxels in a healthy participant's brain that we know are following the plot of the movie. And I obviously wouldn't be showing you this if this wasn't a successful result. Those are the voxels in red in the patient's brain that are highly correlated with the plot following voxels in healthy participants. So based on this, we concluded actually that this patient who appeared to be comatose at the time that we scanned her, actually we concluded that she had at least some preserved level of conscious awareness, a level that was sufficient at least for her to be able to follow the plot of the movie. And I can add that this patient actually went on to make a recovery. So it's very early days. We have very little data at the moment, but I think this is very good preliminary evidence that this simple task has both diagnostic and prognostic potential. It can both tell us whether a patient is actually unaware or whether they have some residual conscious awareness, or and whether they have any likelihood of recovery. But of course, we have to test many more patients to be absolutely sure about that. I said it was a simple paradigm, and many of you may be thinking, well, this isn't very simple at all. We've got the narrative of a movie playing in the scanner, but actually, compared to other classic tasks that we've come up with in the past, like getting people to imagine playing a game of tennis, this is much easier. There are no instructions. You just start that, you put the patient into the scanner, you start the narrative playing, and they passively just listen and hopefully perceive or comprehend the contents of the movie. I'm just going to end by revisiting some old favourite data. I'd be surprised if many of you have not seen this slide before. Of course, it comes from our 2006 science paper, in which we used mental imagery, either imagining playing tennis or imagining moving from room to room in the house, to show that a patient who was presumed to be in a vegetative state for a number of months was in fact responsive. She produced activity in her premotor cortex when asked to imagine playing tennis, just like a healthy participant, and activity in the lateral premotor cortex, the parietal lobe, and the parahippocampal gyrus. Again, a pattern that was very similar to healthy participants when we asked her to perform spatial imagery. This test has now been conducted on hundreds, even possibly thousands of patients, and it shows that about 20% of patients who are thought to be in a vegetative state, or who behaviorally appear to be vegetative, in fact are conscious and aware. Now, you know that, or some of you will know that, working in collaboration with Stephen Lorries and his team in Liège, we went on to use this as a simple method of communication in a patient who appeared to be vegetative and had been for a number of years. And in this case, again, we asked the patient to imagine playing tennis or to imagine walking around his home. But the trick here was to say, well, we're going to ask you yes and no questions. If the answer is yes, imagine playing tennis. The answer is no, imagine walking around your house. And by decoding whether the patient was imagining playing tennis or imagining walking around his house, we could determine simple yes and no responses to a series of questions that he had been asked. Now, what I'm going to end with today is, well, can we come up with some kind of analogue of this approach that we could even use in the ICU, in the acutely brain-injured population, to actually communicate with a patient who might otherwise look comatose. Now, we can't do it with fMRI. It's simply too cumbersome. I mean, we can move the patients to the fMRI scanner, but these paradigms generally take way too long and they involve way too much for us to be able to do it in a very vulnerable, acutely brain-injured patient. And this is where we've turned our attention recently to FNIRS, or functional near-infrared spectroscopy. And one of my current postdocs, Andrew Abdelmalak, has done a lot of work using time-resolved FNIRS, and he has come up with a method of communicate, or a method for patients to communicate in the ICU using just tennis imagery. Now, this is our NearX state-of-the-art FNIRS system that we are now starting to use, but most of the development work that Andrew has done has used a much simpler system, that was built here in the lab in London, Ontario. And the reason why I say this is because when you're looking for evidence of tennis imagery, one of the great things about that particular paradigm is we're only interested in activity in the top of the head, in the premotor cortex. Really, we don't care what the rest of the brain is doing. It's convenient with fMRI to be able to see what's going on in the rest of the brain, but the signal we're looking for is a single signal over the top of the head in the premotor cortex. Thus, you don't need a whole head FNIRS array to detect that signal. We can just put some detectors over the premotor cortex and ask the patient to imagine playing tennis and look for a hemodynamic response there. And that's exactly what Andrew did. He's published a series of papers over the last few years on this, showing that we can produce a level of accuracy that's almost equivalent to fMRI. In fact, there's very little difference at all between the FNIRS and the fMRI. This is, of course, a bedside technique. We can do this while the patient is lying in their bed at the ICU, so we can take the equipment to them. So in that sense, it lends itself much better to the acutely brain-injured population. So does it work in patients? Well, I can present data from a single patient right now confirming that yes, it does work. So this is FNIRS data from a patient who was in the ICU with Guillain-Barré syndrome. It wasn't clear whether the patient was still aware, nor whether what the patient's wishes were. In this case, the patient had elected not to be sedated. The clinical team wanted us to investigate whether this was still the case. At the time that we assessed him, he was entirely non-responsive and had been for many days. All you really need to understand here is the difference between the red and the blue lines. Baseline is when he was asked to just relax. Then we asked him to imagine playing tennis, and you can see these two lines diverge very clearly, indicating that he is responding. His premotor cortex was responding by imagining playing tennis. And then we were able to ask him a series of questions. The first question, of course, we're very interested in, the clinical team were very interested in, is, are you in any pain? Now, you can see there's no divergence between the red and the blue lines. It's just like the baseline. And this is because, in response to "Are you in pain?", the patient was not imagining playing tennis. And I should say, what he'd been instructed to do was, if the answer is yes, imagine playing tennis. If the answer is no, just relax and do nothing. So there was just a single task that he either had to do or not do. So we concluded, and we replicated this, we concluded that he wasn't in any pain. When we asked him, do you feel safe? This was a question that the clinical team wanted us to ask him. And it was related to other questions about whether he wanted to continue in this situation without sedation. There's a very clear divergence between the red and the blue lines. He very clearly started imagining playing tennis in response to being asked, do you feel safe? And that, of course, is the indicator for a yes response. So I've told you everything that I want to tell you today. As I say, in the last 2 years, I've really pivoted the work of my lab away from the chronic brain injured population into the ICU, into the acutely brain injured population. And hopefully I've convinced you today that we're going to be able to generate very much the same sort of data, the same results that we have done over the last 20 years or so in the chronic populations. And that is that functional imaging methods, in particular fMRI and FNIRS, they will be important diagnostically. They'll be able to tell us whether patients have residual cortical functions, including conscious awareness. They will be prognostically valuable. They will be able to tell us which patients are most likely to recover and who is least likely to recover. And of course, that's exceedingly important in the acute setting. And thirdly, I believe that in some cases, probably very few, in a minority of cases, but in some nevertheless, we will actually be able to open a channel of communication at the bedside using time-resolved functional near-infrared spectroscopy. So I really want to thank you for your attention, and also to acknowledge the many collaborators, postdocs and students that have worked with me on the research I presented today. If you'd like to read more about this, I do have a book, Into the Grey Zone. It's been translated into many different languages now, and it describes this journey from the early days of imaging, when we were really just beginning to try and understand how we could use some of these methods to investigate serious brain injury, right up to the current work using techniques like functional near-infrared spectroscopy, where we're really probing residual consciousness in some of these patients. And of course, I'd like to thank my funders as well, everybody that supported this work. And thank you very much for listening.
好的非常精彩的演讲，就是这个欧文今天的演讲里边信息量非常大，给我们透露了很多很重要的信息非常的棒。那么首先呢，他可能欧文，这是我第一次听欧文的演讲和讲课，他可能不是一个特别擅长讲故事的，或者条理性感觉没那么容易抓取的。但是你一旦被带入之后，发现它里边真的是蕴藏的非常强大的这种思想和思维能力。那么他这里边的，今天我总结一下他的 PPT， 讲得很长。那么大概的有几个主要的结论，就是他发现使用静态的这种功能磁共振的方法呢，发现了很多人有语言甚至对于外界的反应。但是他的结论呢是，这些静态的这些信息呢，并不一定和意识相关，尤其是在慢性期。那么在早期呢，可能还带有某些预测因素，而在慢性期呢，它可能对于意识的相关性就没有那么直接了。这是他的第一个结论。因此他后边的推进里边又提出来，后边花了很长时间去讲这个希区柯克的这个默片的电影他讲了很长时间讲了这个，他主要讲的是一个范式实验范式。那么我们知道，在做这种功能影像检测里边的实验范式是非常重要的。那么在我们常用的范式是欧登堡的这种实验。那么在欧文这些年呢，就开创了很多这种用于功能检测的这种范式。那么刚才讲的，它也是一种希区柯克通过看电影的一种实验的范式，这是非常重要的。范式是研究的一个重要的工具。那么研究工具的人是能够带动领域里向前，是大步发展的，是能够带来革新性的。所以他讲很长，可能大家有些不得要领，但实际上他讲一种新的范式，如何去检测这种连续的动态的意识，以及去看哪些指标或哪些区域，这是非常对我们有启发性的。那么他的第二个结论，讲了很多范式的结论，就是对于这种连续的思维和连续这种情节的追踪，对于意识的判断是非常准的。那如果他能够进行这种视觉或这种情节的连续追踪的话，那他的意识几乎判断是没有问题的。那么最后一部分他又讲了一个新的技术的方法，就是 FNIRS 近红外光谱技术。那么他刚才讲到了，如果静态的这种 crossover 的这种检测不能够作为很准确的检测的话，那我们一定要使用一个连续的。那么在影像里边呢，现在 FNIRS 是给我们提供了一个很好的连续的双旁观察的方式，能够正好和他前面的结论动态的最终可以去检测出更好的这种意识。所以说我觉得他这个发言虽然讲的好像条理性没那么好，但是实际上信息量是非常大的。那么在最后的他的发言的最后部分提到了一个非常重要的他的一个大作，就是这个进入了灰色地带的生命之光，我们中文翻译成的这本书这本书呢我们已经近期狄海波教授的团队的胡老师以及狄海波教授呢都已经把它翻译成中文了。这是一本非常重要的书籍这本书呢我看过2次 里边的内容非常的多，而且能给我们带来更多背景的知识。我们知道欧文在我们的慢性意识障碍领域里边是非常重要的研究者，但是他的生活的背景大家不了解，他可能他的母亲早年呢，由于恶性的脑肿瘤呢，在很早年就死亡了是因为恶性脑肿瘤，说他一开始就接触了很多跟影像和神经系统有关的。那么他的女朋友呢，因为一次车祸呢，也变成了植物人。在这期间呢，他还给他的女朋友前女友那么做过很多的功能自共振检查，发现呢他是有意识的，但是在这个过程中间他非常的无力，尽管他很早就发现他有意识，但是最终呢也没有改变他的结局，最后还是死亡了。在这个过程中间呢，他讲了很多人文的东西，因为他是能够作为病人的家属能够感同身受的知道这些植物人的这种心路的历程，所以在里边他讲了很多人文的东西。那么我们在植文的研究和慢性意识障碍研究里边，除了我们在追求技术的精进的时候，其实还是应该有一点人文和伦理的情怀在里边，因为毕竟这里边涉及了很多伦理的问题。所以我觉得这本书呢，对大家有很重要的一些帮助，我是强烈的推荐大家去看，我自己看了2遍，内容非常的好。这里边他除了讲到了他站在一个家属的角度，或者站在一个研究者在很高的高度去观察这个内容的基础上，他还讲了很多技术的背景。比如说他刚才讲到的很早的发表的 CS 这一篇打网球的这个研究，发表非常轰动的带有革命性的这个研究里边，他在这本书里有专门的详细的讨论，就是为什么当时选择了打网球的这种实验范式。那么这里边也强调，大家都知道打网球这个实验可以用来功能自动检测，但是这里边大家还知道，他这里边还特意强调了，在扫描的过程中间必须要持续30秒钟才能够做出这种过来。在这本书里他也详细的解释了为什么要用打网球，他选择了很多种范式，进行了很多种比较。那么在这里他也讲了，最后选定的是打网球，而且时长必须要30秒钟。这里边有详细的讲解，所以大家呢希望能够在这个书里边能够获得更好的。包括在看这个希区柯克的这个默片，在这本书里也有详细的描述，他早期的。当时他在到了加拿大以后，拿到加拿大资助以后，在加拿大做这种希区柯克的默片但是我今天的演讲可以看到，在这本书的基础上又有很多新的进展我相信呢，大家在这本书里边能够更加深刻的理解了，就像欧文这样一个非常有思想深度的一个研究者的内容，无论是技术本身以及对这种人文的关怀。所以最后还是强烈的推荐这本书。我们叶海波老师和他的团队的胡老师花了很多的精力把它翻译成中文，我相信能够让更多的我们的研究者能够去体会这里边很深层次的这种知识和文化。好的那么就是这一个